Mr. Collier has over 25 years of experience as a healthcare executive. Experience ranges from employee benefits to human resources to physician management, operations, delivery of care, you name it. And actually, while with IPC, IPC serviced several hospitals and several systems, several SNFs, even psychiatric facilities. So you kind of see the reach that hospitalists have in the delivery of healthcare. With Wellmont, he's specifically over a directive to integrate a hospitalist service, and it's going to have it's going to be built on a foundation of quality, and there's a component for post-acute integration and a continuum of care. And I think he's going to talk to you about that today. This particular breakfast with the expert, I feel, is going to be very timely for what's going on in the healthcare industry. If I were still in the business, I would want to be here today to hear this talk, because it would help me with my strategic planning. You students that are in strategic planning right now, this would be integral for me, either as a post-acute provider or as an acute provider or any public health profession this is going to touch. So with that, I'll leave it over to Mr. Collier.
Okay. Anything else? Okay. Good morning. I think we're all awake this morning. I hear Colin talk about being in the healthcare business for 25 years. I feel a little bit old anyway, so it makes me feel a little bit older this morning. One of the things I do want to talk about a little bit as we get started is this is very informal, so feel free to ask questions at any time, any conversation. Feel free to stop me. One thing about as we get into integration today, and we talk about the integrated healthcare model, it's important to understand that for really 25 years I didn't believe in integration of physicians. I felt like I'm a very independent person. I felt like the physicians had an independent entrepreneurial spirit, and I never liked to squelch that kind of spirit. Healthcare reform, for whatever you define it, has changed my opinion on that. And it's one of the reasons I left the for-profit world in June of this year and joined a non-profit world to work on integrated models. So totally change of opinion of mine for 25 years, the last 2 or 3 years. One thing I do want to talk about, I'm going to say a few minutes at the end, I want to talk about our hospitalist program that we started back in October, because it is a direct correlation to healthcare reform and the quality-driven initiatives that you now have to have in a physician model. But when I came out of college, I was very fortunate to go straight into employee benefits with a large company called McDonough Caperton Benefits. And the guy that was the CEO at the time, a guy named Andy Paterno, became a good mentor to me. And so I was exposed to a lot of healthcare delivery models on the employee benefits side at a fairly young age in the workforce environment. But he told me one thing that I always remember is that, for any business to be successful, whether it's healthcare, whether it's restaurant business, clothing, whatever, you got to have some common elements. One of them is you got to have a quality product, and everybody wants to have a quality product. I interview physicians. Most of my time is spent interviewing and hiring physicians. I've never had a physician in 25 years say, "I'm just here to provide the lowest quality of care I can provide." Everybody wants to provide high quality, right? So, but you got to have a high quality product, whether it's a product or a service. You've got to have some kind of quality defined in that product. You got to be competitively priced. In healthcare, we're one of the few industries that we don't control our pricing. We get told what we get to charge and what we get to receive. So that's a little bit irrelevant for us. And then that leaves people. You assume you've got the best people in the best places. And sometimes when you don't have the best people in the best places, that's your fault as a manager if you've got them in the wrong place. So you've got to figure that out. And that leads to two things that I focused on and continue to focus on, and that's customer service and relationships. So if you don't have customer service and relationships, you've got no foundation for any kind of business or success. For the first time in healthcare, I'll be at 27 years next year, you start hearing doctors talk about customer service. Why? Any ideas? Where did it hit them at? It's affecting their pay.
Money-based.
Okay. So for the first time, you're hearing the buzz, customer service. Customer service is taboo for years. We don't have customers, we have patients. No, you've got customers. So that's going to tie into this presentation as we go along. The thing we did on the presentation, I know y'all see this stuff day in and day out in your classes and as you have discussions. But I think everybody knows where we were in 1960. 5.2% of our gross domestic product budget. 2009 was 17.6. It's actually about 18.8, 18.9, I think, in 2012 estimate. And in Medicare, in 2009 makes up 20%, and I think right now it's staying around 21, 22%. So Medicare has become the largest absorber of healthcare services in our country, and that's obviously one of the reasons for healthcare reform. When I started in the employee benefit business in 1986, I had a book of business of about 350 accounts across country. I had one account out of about 350 that had a family rate over $200 per month. Okay, for health insurance. Today, I don't think you can find a plan that's got a single rate less than about $350 or $400 per month. The single rate back in 1986 was $45 to $54 per month. Okay, when you compare that, where healthcare is going, you can see the need where everybody's focused on healthcare reform. 6% of the hospitals, or about 500, have closed in the last 3 to 4 years. We closed a hospital in October this year. It wasn't financially based, although that's part of it. It was quality based as much as financial decision. And that's a tough decision when you close a community hospital. Physician Hospital Alliance, very rocky marriage between physicians and hospitals. Not new. For years, you've had the CEOs hospitals, and I did some interim CEO work in hospitals. Some of the best jobs I really had, because when you're an interim CEO, nobody expects anything from you. Nobody gets mad at you. You're not there long term, but everybody wants your help short term. But as a CEO, you get the opinion for years. I'm the CEO. I write your paycheck. You do what I tell you. You need us. We don't need you. The doctor says, I'm the doctor. I'm the smartest person in the room. I don't care who writes my paycheck. You need me. And that's the way it was for years. And very seldom in the hospital business did you have doctors and administrators sitting down together. So if a doctor came to my office, what was my initial thought? What does he want today? More money, more equipment, more staff? He's asking for something. If I show up in his office, what was his thoughts? He wants me to see more patients. He wants me to produce more money. He wants me to use less staff. He wants me to use less equipment. That was the adversarial relationship for years. That has changed the last 3 or 4 years. And once again, because the revenues have gone down, everybody is struggling to find ways to work together. So healthcare reform, with all its pluses and minuses, one of the pluses is it's making administrators and physicians sit down together and work together. And the patient benefits from that concept. 1990s, hospitals started buying practices, and we did it very poorly. Now we're in the process of buying practices again, integrating physicians, and we've learned from the previous mistakes. So I think you'll see that as we go through the presentation. Accountable care organizations, I know you guys know them inside out. If you do, you know more than the government knows about them. Right now, we're on a 3-year look-back period. With ACOs, we're actually in our first year, and they don't know what they're going to do at the end of 3 years. They still can't comprehend how to define the quality return bonuses, etc. So at the end of the day, I'm not sure what the end result of the ACOs will be. Once again, if nothing comes out of the ACO market that they think it will, it still has produced the relationships and the more efficient delivery of health care. So again, it's accomplished a mission, although it may not have a different mission than mine. Physician employment. Right now, probably in the Tri-Cities, I would say 60-65% of physicians are employed by the 2 health systems. That's probably going to be 85 to 90% in the next 18 months. 10 years ago, that's probably 20%. So to give you an idea, everybody's heading in that direction. Fear and panic causes a lot of that, and usually that's when bad decisions are made. But in this situation with healthcare reform, it's forcing good decisions for the first time. So I think you'll see that. Hospital and healthcare system consolidation. If we proceed from now through 2020, it's very possible you would only see a few health systems in each state. And I really think Mountain States and Wellmont provide cities that's got to eventually become one system. How and when that happens, I don't know, but I think you've got to go to one system in an area this size. Today's reality, if you're a physician or hospital, operating costs have to drop by at least 20% in the next 3 to 5 years. The reimbursements keep going down. This isn't speculation. This is reality. So if you've got a private practice and you're generating $3 million in revenue through your practice, you're going to generate about $2.4 million in about 3 years. So where's that $600,000 come from? You can't lay off staff, because you're probably bare bones staff anyway. Can't reduce equipment. You probably got the minimum equipment that you need. That comes out of the doctor's pockets. So you're going to see that continue to be pressure on each doctor and hospital. About 1 in every 20 acute care hospitals will close by 2020 if we stay on the same track. And that's going to put more pressure on the healthcare systems that survive. There will be winners and losers. The strong will survive, and the weak will not survive in the healthcare reform market today. And that sounds bad, but at the end of the day, the patient's going to benefit the most. And one thing I've said for years is we tend to, I'm trying to say how to politically say this. Hospital boards of directors traditionally don't know a lot about the hospital system. They're traditionally local business owners that get away on a board of directors, and they really don't understand healthcare systems, period. We've done it, I think, at Wellmont, a very good job the last 18 months educating our board of directors on you just don't look at financial statements. And where you might have a loss in one statement, it's really an investment because you're recovering money in another statement, part of the statement. Where traditionally they've looked at this statement and said, okay, we lost $600,000 here last quarter, get rid of that department. And that's the way we've operated in healthcare for a long time. We can't continue to operate that way. You've got to look at certain losses as an investment if you're getting the return somewhere else. So I think you're seeing, the hospital boards of directors and the communities are starting for the first time to get more involved in how does healthcare really work, not just the fact that I'm sitting on a hospital board and it's prestigious. It's not prestigious anymore. We are in a depressed economy as far as healthcare goes, and it's impacted all of us tremendously. One of the things we're seeing, I'm going to jump ahead just a little bit, is the reimbursement levels we've talked about. But the other thing we're seeing is a lot of employers are going to large deductible plans, which means that people are choosing not to have elective procedures right now. So elective surgery, for instance, is down about 60% at Johnson City, down about 70% at Houston Valley, and about 50% at Bristol. That's huge volume for us. So all of a sudden our outpatient surgery, elective surgery, that was a huge moneymaker for us, we're really struggling. Both systems are right now with how do we recover from that. Because you go from a $500, $1,000 deductible to $5,000 deductible, and you got to put $2,500 to $3,000 up front to have that surgery. You'll postpone that surgery now. So these deductibles are having a huge impact. Eastman Chemical is going to a large deductible plan next summer. That's going to have a huge impact on the Wellmont system, and we know that. We're already anticipating that impact. And we went to a larger deductible this year. We went from $250 to $1,000. So we even made a decision to go that direction.
What are some examples of some elective surgeries?
Well, I think talking about elective back surgery, elective surgeries on shoulders, knees, hips, things that can be postponed or put off. The other thing we're seeing a huge is like MRIs, CT scans, elective outpatient testing, where you've got to pay so much up front. Those tests are being put off. So right now the CTs and MRIs are way down for elective or scheduled type procedures. Right now we're also seeing physicians are really choosing employment for lifestyles. And there's a difference in work ethic today in physicians, and I hate to say that across the board. It's not true for everybody. But the work ethic of a 60-year-old doctor today is better than a 30-year-old doctor today. And that's just the reality. Very few residents anymore. We hire probably 2 or 3 a year out of maybe 100 physicians that we're looking to hire. So part of that's just there's many experienced physicians available, but they want to come out of medical school. They want to work 8-hour shifts. They want to be home at 4 o'clock in the afternoon. They don't want to do call coverage. So they're choosing to be employed to find those situations. Money's not the driving factor for the young doctors today. I'm not sure why, because some of them are coming out $300,000 in debt. But it's not the driving factor for their employment today. Healthcare reform objectives: increase the number of insured, decrease the number of uninsured, obviously. Lower reimbursement, better outcomes. For the first time, we've got legislation that's focused on quality. For the first time. In the 1990s, everybody started panic when Mountain States and Wellmont systems were formed. They really were formed out of a little bit of a panic situation because the buzzwords in the 90s were capitation and HMOs. Everybody familiar with that? Capitation, all it is a fancy way of saying cost shifting. What the insurance company said is, we're going to make our 30% profit, we're going to cover our overhead, and we're going to give you 50% to cover your expenses for treating our insureds. That's all it was. It's cost shifting. Today's healthcare reform is more quality driven. It's not cost shifting. There is some cost shifting involved, but it's quality driven, and you're going to be based on that quality. And I've said for a long time that instead of worrying about the bottom line, if you worry about the quality, and the quality is at a certain point, the financial picture takes care of itself in healthcare. The reason being, if the quality is at a given point, you don't have to duplicate tests, you don't have to duplicate services, and that's where you lose a lot of money in healthcare. So if the quality is at a certain point, the finances sort of come into line. This reform is really helping with that more than anything in the past. And we also have incentives for IT. We're spending probably, I don't know what the latest number is. We're going to spend probably around $150 million on our new electronic health record system called Epic. We go live next Monday in our doctor's offices. We go live March 31st in the hospitals. But we've got money that helped offset some of that cost through the Healthcare Reform Initiative. So you're seeing that take place. And that's another positive for the patients. Healthcare legislation, I think you've probably discussed most of this. So these are things that are really coming into play that we're looking at down the road. 15, 20 years ago in hospital administration, we talked about what we're going to do in 2 years, 5 years, 10 years. Sometimes we talk about what we're going to do next week right now. I mean, it's to that point. Healthcare is changing so quickly, we don't have 5-year plans anymore. We don't have 2-year plans anymore. We have capital improvement plans that go out that far. But as far as operational and delivery of healthcare, we're almost on a week-by-week, month-by-month situation right now. And sometimes it's purely speculative decisions that we make based on what we think is going to be the result of certain legislation or change in healthcare. Importance of physician alignment. We've talked about the physicians and hospitals have to work together now. They don't necessarily have to be employed by the hospitals, but they've got to figure out a way to work together. It's got to be some kind of joint venture, partnership, and it's got to be more than a handshake. It can't be, glad to have you around the area, Dr. Smith, we're going to help you out. It's got to be a written type almost agreement. This is what we're going to do for you. This is what you're going to do for us. And that's sort of the way it's got to get to. We don't want to remove the independent model from the physicians. You can have a lot of entrepreneurial spirit in a large organization. I think in our organization, one of the reasons I came back to a healthcare system after really being out for about 15 years, and I chose Wellmont, was because I felt like there's a lot of entrepreneurial spirit in the leadership team at Wellmont, and I think they understand the need for change. I also think that sometimes as physicians, and we have some very good physician leaders in our organization, but sometimes when you're involved in patient care every day, you postpone making really important decisions that affect everything, and tough decisions you have to make. If you're afraid to make the tough decisions in today's healthcare environment, you won't succeed. You've got to be able to face the tough decisions and make those and live by those decisions. So what makes it so difficult? Sort of summed it up a while ago. The approach is being you work for me as a doctor, you'll do what I tell you, I sign your paycheck. And that's the absolute worst situation you can ever have. You find good people, you find key people, you find doctors, administrators, managers, etc., and you support them and let them do their job the way they can do it with their abilities. But we traditionally have tried to dictate to doctors what we can do, and in the same process, doctors have tried to dictate to us what we can do. And it's been a very adversarial relationship for a long time. That has changed tremendously the last 2 to 3 years. We looked at medium and long timelines. Doctors look at short timelines. How do I pay for this piece of equipment? How do I hire this extra nurse? How do I get a bonus out this month to take my family on vacation? Things like that. It's a very short-minded approach when you're in private practice. We come up with the economic accountability. The physicians have the clinical accountability. Now they've got to be one. Okay, so they've got to be one. And of course, the stressors on physicians and hospitals. At the end of the day, a lot of physicians that have joined me at Wellmont, have worked with me in the past, at the end of the day, they just want to be a physician. They want to take care of their patient. They want to provide the highest quality of care they can do. They don't want people standing behind them, telling them, you got to discharge this person today, you got to fill out this form today, you got to get approval for this extra day today. They don't want that. They want to practice medicine. They want to be put in an environment where they get to thrive as a doctor. And that's a very welcome relief in today's environment. And it's one of the reasons at the end I want to talk about our hospitals program. We've created that environment at Houston Valley very quickly with our hospitals team, and the results have been phenomenal in 45 days. Factors contributing to integration. There is a common need. We talk about finances and etc. There is truly an underlying thought process that we're here to take care of our community first. And I think every physician feels that way, and I know all the hospitals feel that way too. There is a decrease in physician revenue, increased cost in their care, and increased competition. over things that normally belong to the hospitals the last 10 or 15 years now don't necessarily belong to the hospitals. You've got standalone MRI and CT scans. You've got labs. You've got outpatient testing and physician offices. Most physician offices that are independent that have labs and outpatient testing, that's where they're making their money, not necessarily in seeing patients. And you talk about new hospital physician arrangements. One thing we did at Wellmont, and they actually did it, and it's another reason I joined Wellmont this year, is they had a group called Wellmont Physician Services, about 120 physicians and providers, and they felt like it was not based on the quality-driven model. They disbanded that whole group about 18 months ago, and they created Wellmont Medical Associates, and they built a group based on quality. And in 18 months, that group has about 250 physicians in it. It's received national recognition for quality. And the doctors lead that organization for the first time, not administrators. We have 17 members on the board of directors, 14 are physicians. The top 3 office positions are all physicians. And they sit around, we have our board meeting, tomorrow night's our monthly board meeting. They talk about quality of care and how do we provide better quality. They took a 3% at-risk compensation model 3 months ago based on quality initiatives. So they said, we're going to take a 3% cut, we're going to put that 3% at risk. But we think we'll get it back because we're going to provide the quality to get it back. What that does is let us go after more aggressive contracts for the hospital, secures more business for them. But they are making these decisions for the first time, not being told you're going to take a 3% cut. Physicians, they always worry about call coverage. And as a shortage of physicians comes about, the younger doctors don't want to do call coverage 24 hours a day. That's becoming an issue and a challenge to fill. So that's another reason physicians are looking to be employed. Assistance and capital to keep pace with new technology. If we're going to Epic, and it's costing us probably $250 million total, and you ask a doctor's office to spend $1.5 million, $2 million to go, they don't have that kind of money in a small setting anymore. So they've got to have help to bring the IT capabilities into their office setting. Current environment, we've talked about it, forces physicians and hospitals and administrators to work together, and that's a great benefit of the healthcare reform right now. We actually, at Wellmont, I think I've got a slide in here in a few minutes, and some of these slides I'm going to breeze through because I do want to open the floor for questions, but we actually have gone to DIAD, partnership with physicians. Is everybody familiar with the DIAD, relationships in business? Anybody? Have we talked about that, Colin?
No.
Okay. What we've done at Wellmont is that the senior administration, we have DIAD physician partners. I have one at Bristol, I have one at Hostin Valley. We talk or meet weekly. And he's got a voice through a department. I have internal medicine at Hostin Valley, and I have family medicine at Bristol. And we talk every week about what's going on, what are the needs, what's coming back up through from the other physicians, and I report that back to the executive leadership team. And then we have meetings jointly. And so where the physicians have a say at our board of directors and our executive leadership team, which they never had before. And we actually have physicians on the executive leadership team now that come out of the DIAD relationships. But it gives accountability to them and accountability to us that we're communicating at least once a week or meeting once a week and talking about the needs of the physicians, not just the needs of the hospitals. So we've gone to DIAD management, which is a great concept. We actually have physicians in the organization now, and it's very common, I think, throughout, that they do very little clinical work now. We have 3 physicians that basically do all administration work. They work a few clinical shifts a month just to keep their skills up, but it's only for their own choosing. So you're seeing physicians even come out of clinical practice and participate in the decision-making process on the hospital side. We've talked about most of this. I mean, for us, we're protecting market share with integration. We're preserving existing physician practices, and we're creating leverage with our payers. Right now, one of the reasons we started a hospital service and integrated it is if you go to a ACO or you go to an at-risk payer, and they ask, well, who provides your hospital's coverage? And you say, well, it's an independent company, and they'll want to know, is it production-driven, quality-driven? What's production-driven? Well, thanks, but no thanks. We're not going to give you a contract. So the hospital's program has to be the core of the at-risk contracts right now. So we've developed our own integrated model based on quality, and that's going to open up some additional contracts for us that we didn't have access to in the past. One thing we are working on is continuation of care and patient experience, and part of my responsibilities are also on the nursing home side, which is where Colin and I connected when I was with IPC. But we actually bought our first nursing home yesterday. We made the announcement officially tomorrow, but we bought Wexford House in Kingsport. And part of that initiative is that we've got a 60-day plan of care in place that we're going to be watching the patients from the hospital stay to the SNF setting to home health back to the PCP, and we're going to account for that patient every day. We're going to profile that patient for high risk for readmissions. If it's a CHF patient, they're going to be a 1 to 4 grade. If it's a 4, we're actually going to send a cardiologist out to the SNF to see them the second day they get there. So we're bringing cardiologists and pulmonologists out to the SNF market to try to prevent the readmission. 30-day readmission rates, we took a $1.6 million hit last year at Wellmont. We're working a 60-day plan of care. Why? Anybody want to guess?
Because you're penalized for readmission within 60 days.
Right. And what's Medicare probably going to do eventually? Go from 30 days to
45.
Right. That's exactly right. So we're trying to get a jump start on that process. We are really far along in our post-acute initiative. I actually started with Wellmont about 18 months ago in a consulting role with IPC to start the post-acute initiative. And right now we're getting ready to do some guest lecturing with Texas, and I think we're going to be in Vegas in February, and we're going to be I think actually we get a trip to Hawaii, believe it or not. The consultant we use has a large client in Hawaii, and all of a sudden post-acute's become a big buzzword, and we are so far down the road, and you'll see in a few minutes what I'm talking about. But that, again, the driver for us is not only do we want to know where the patient's at the whole time, what do we want to do with the patient? We want to keep them where? In the Wellmont system. We know in our ACO right now we have 12,000 Medicare people. We know on our pulmonary disease people, we only capture 40% of the revenue. On our cardiology ACO, we capture 85% of the revenue. What's going on with that 60% of pulmonary? So we're even diving down to that degree of what are we doing wrong in pulmonary, that we've got to get more of the ACO business back and stay in the Wellmont system. So we're trying to prevent readmission. We're looking at 60 days out. We're tracking the patients. We're bringing in specialists. But at the end of the day, we're trying to keep them in the Wellmont system. Who benefits from that process? Patient. Healthcare reform for the first time. Colin can tell you in the nursing home business, for the first time, and I said this 25, 30, or 26 years ago, nursing homes were treated like a stepchild. This Reform Act has come through in 2009, 2010, has put the spotlight on nursing homes, which will benefit the patients, benefit the nursing homes. The nursing homes haven't all been prepared for it. Some have been more prepared than others. But for the first time, we're giving attention to these patients that are 80, 90 years old, 70 years old, that we kept in a hospital for 8, 10, 12 days. We ship them out. We wish them well. We'll see them back in a day or two. Now we're not doing that. They're getting the same care that you and I get by walking in the doorway of the hospital. So that's a huge plus to that population of people with healthcare reform. Physician, we talked about all the reasons for the integration. Successful physician integration, first of all, it's got to be totally transparent. And you'll see transparent come out through a lot of this process I've got at the bottom here. It really should be first. Transparency should be the first thing. If a physician feels like you're not being totally transparent and open with them, you never get their trust. And when I interview physicians, we've already checked out their clinical. We know clinically they're a candidate. They've been through enough of our interviews, and we've done our background research. When we meet with them for the first time, we talk about expectations. We don't talk about clinical issues. We don't talk about things like that. We talk about expectations. You know, we expect you to be here at this time. We expect you to treat your patients and see families and have family meetings, and we expect you to represent us and yourself in the highest, element of professionalism. I mean, we talk about expectations. You know, if you lose your temper of nursing staff or case managers or families or patients, you're probably not going to work for us long term. You know, those are the conversations we have. And we set those, we talk about those expectations, but they appreciate that. And as a matter of fact, we had a situation just a couple of weeks ago with a part-time physician, young physician, that really was mishandled the situation. And when I spoke with him, the response was, "Thank you for being willing to discuss that with me." They appreciate the full transparency, and they want to be held accountable, just like we want to be held accountable. You've got to engage the physicians in the metrics. You've got to let the doctors tell you what do they want to focus on. Right now, we're working on an initiative on blood pressure. Sounds simple. We're working with, I think it's 36 health systems across the country. It's a major program. I think it affects something like 48 million people. And it's an 8-step blood pressure monitoring every time they come into the physician office, and we report the results back. And we're doing it at the Cleveland Clinic, Mayo Clinic, Kaiser Permanent, and some other places. And the end result is blood pressure seems to be an indicator that creates other issues, and it's becoming a large cost in the healthcare system. So there's a nationwide push to keep blood pressure controlled in a certain situation. First step is taking blood pressure the proper way. Put your feet flat on the floor, sitting upright, arm extended out, not feet crossed, legs crossed, etc. So we're even going back to the basics because all that comes into play in healthcare. You got to be prepared to deal with poor performers. Okay? So if you've got a physician group led by physicians, and a physician is not performing well clinically, quality-wise, or just customer service-wise, who's he accountable to? Not us, but who? The other physicians. Who better to hold physicians accountable than physicians? So if I'm on a board of directors and I've got 200 physicians and we've got one that's embarrassing us, what are we going to do with that physician? We're going to deal with it, which means we're going to sit down, put a plan in place, try to work it out. Ultimately, that physician may not be part of the group, but the physicians are now holding physicians accountable because they see the need for the quality-driven outcomes. Learning from the past, the only thing I can say is we did a very poor job of physician integration the last 20 years. We're doing a better job the last 2 years. You got to make sure that your system is willing to accept physician leaders. There's a perception that if doctors are leaders in your organization, you don't have a whole lot of good leaders in your organization. And that is so far from the truth. First of all, you got to be fairly smart to get through medical school. Everybody agree? And they're on the front line delivering the care. Who better to affect the operational side of the business than the person delivering the care? So you've got to sell that concept to the systems. It's okay to have doctors in our leadership team. That's the most enjoyable part of my day is working with my dyad partners. They have easy access to the CEO. That's not always easy. Our CEO leads a 7,500 employee group. We see her probably twice a week in executive leadership team meetings. We have access to her, but we have physician leaders that have access to her. They can pick up the phone, can send her a text or an email, and she will immediately step out of any meeting and respond to that doctor in that approach. So we've made that known. The doctors go back and say, hey, I called Denny 30 minutes ago. She called me back immediately, and we got this resolved today. I mean, they've got that access to our CEO. You got to have people experience in physician management. So we got to have the quality physicians, we got to have physician leaders, but you also got to have the non-physician leaders that understand the working relationship with physicians and the management of physicians. I always compare it as this. I've probably hired 600 to 800 physicians the last 25 years. I've probably worked with another 400 or 500 through PHOs, etc. And physicians are a lot like thoroughbred racehorses. Everybody understand that analogy? They're extremely good at what they do, but each one's got a different spirit to them. And you got to figure out what that spirit is that you can play to get that trust with that physician. Once you lose a trust in a physician relationship, you never get it back. By the same token, once you lose trust in that physician, you'll never get it back. So it works both ways. But you got to have full transparency and full trust in that working relationship. You got to be able to handle the bad news with the good news. Everybody likes to deliver good news. Very few people like to deliver bad news and deal with it, but today we're being forced to. And actually, it's resulting in better relationships. So it's not bad. We will do everything for everybody. Has never been a viable value proposition for any successful business, but yet it's a value proposed to the hospital systems. We're being told, you take care of all their needs, here's what you get to take care of it with, and oh, by the way, we expect this kind of outcome and quality at the end of the day. So if you've got any interest in going into healthcare, which obviously you do, you probably picked the most boring time in the eternity of healthcare you're going to, right? That's part of the conversations that Sherry and I have regularly, both being in healthcare, is that most times we're at dinner or something, and most of our time is talking about healthcare. And we're talking about the customer service side, we're talking about the delivery side, we're talking about a lot of things. But the healthcare is changing every day, so we really couldn't be coming in at a better time. I really believe that. Hopefully I'll be out of it by the time y'all can really get into it. But remember, each market, each hospital, each community is different. I treat Kingsport different than I treat Bristol. When I'm at Bristol Hospital, it's a different environment than Houston Valley Hospital. My physicians have a different mentality at Bristol than they do at Houston Valley. Don't know if it's the building, don't know if it's the staff, don't know if it's the type of patients we deal with, but it's a different mentality. So we don't apply the same principles, same operating policies at both systems unless this is a generic type policy. We try to take an area we've got to make improvement in, we tailor it to that hospital, to that community, to that doctor. I'm going to breeze through this, but this is a national study, and I've got several slides here, but I just wanted you to see sort of the credibility of the study that was done. 3,000 Society of Healthcare Strategy and Market Development members were surveyed, physician leaders and CEOs. 362 responded from 300 hospitals, and they did over 60 interviews by phone. This is how it broke down. 33% of the responses were for hospitals with 300 plus beds. And you can see 28% from president and CEOs, 20% from physician relations, 17% from physician leaders responded. Here's what sort of things that came about. Hospital relationship with members of the active staff. 47% said they're doing very well. Active staff. Relationships with referring physician, 33% said they're doing well. There's a mentality that if you're an independent physician, you're going to be cheated by the healthcare system that you're in business to. Okay? There's still that mentality. They don't trust the healthcare system because they think we're out to put them out of independent practice business. We're trying to change that to say you can stay in independent practice business, but we still got to work together. But you can see there's a difference there. So the people that are staffed with us in the hospital system have a lot higher response to satisfaction versus the ones that still have a lot of fear. And same percentage here you can see. If you look at the top, what we talked about, transparency, the biggest challenge they felt like from 223 of the responses were communication, openness, trust, and respect. Basic philosophies. We've got a common goal. We're going to provide the highest quality of care, best outcomes, most efficient manner for our patients. They're going to benefit at the end of the day, but you got to be fully open and transparent with us as we go through that process. So you can sort of see some of the things that came out. What were the physicians? How many of these you think were physicians' involvement in decision making? I bet you 90% of those 152 came from physicians. Because traditionally they feel like they had no say in decision making in healthcare systems. And this is the slides I'm going to breeze through, but you can see there's a very in-depth discussion, very in-depth interview. I mean, they went through a lot of the details in great detail, comparing them. 5 and 6 were the high scores. Yes, if they have the service, and you sort of see how it falls into play. Retreats. 39% of the hospitals said we have retreats for physicians and senior management, not just one or the other. 70% of the respondents said you need to have them. Again, probably high physician input on that 70%. Okay, you got to hear that. It's common throughout. We want to be heard. We want to work together. So you got two options: you either become partners or you become competitors. And my approach on competition is if you're nearly as good as you think you are, don't be afraid of competition. If you're not nearly as good as you think you are, you better run. Everybody understand? I'm not afraid of competition. I love it. But I want to make sure I got something to take into the competition. Same thing here, tactics. Employee intensivist, employee hospitalist, 51% said we do, 74% of the respondents said you need to. And that's what we just recently did. I'll talk about in a few minutes. Clinical information systems, very high again because of healthcare reform subsidies. Practice growth, you can see some of those are fairly common. 10 most effective tactics, hospitalists and intensivists at the top again. But look where they actually are. Only 30% of the facilities, 300 facilities, actually employ intensivists. And that's an issue right now because there's a shortage of intensivists. Everybody know what an intensivist is? Critical care doctor. Okay, that's probably the short term. Somebody goes to the ICU and stays all day and does all the dirty work. Okay. Keys to success, we start with, again, we use this in our WMA organization, but we start with communication, openness, trust, and respect. And this is the actual alignment process that we look at some. Low degree of alignment to the high degree of alignment. High degree physicians active on board and executive team. That's a new concept to a lot of people. In the past, we gave them medical directorships. We said, Dr. Smith, we like you, you're doing a great job. We're going to give you $30,000 a year to be medical director. Don't want to see you again. Okay, don't give us your input. Don't give us what you think. We're going to pay you to be quiet. True?
Yeah.
True story. Give you $30,000 a year to be quiet. You're a medical director. Now we've got them on our board. We have them on our senior board. We've got them on our Wellmont board. 4 physicians out of 16 spots are physicians on our executive board. Dyad leadership models, just talked about a while ago, has to be dyad leadership. It's got to be winners on both sides. Shared strategic objectives. We do a good job of setting strategy. And this is not just healthcare, this is all business. The leaders do a good job of setting strategy. We sometimes do a very poor job of communicating the strategy. Oh, we put a plan in place to reduce readmissions last week. If you went and interviewed your staff, probably 10% of you could tell you what that program was. So in the past, we've done a very poor job of communicating the programs. But anyway, you can sort of see everything's moving in that direction. Bundle payments. Everybody heard the word bundle payments? Bundle payments will eventually include nursing homes. So we're going to get X number of dollars, and we've got to disperse that funds to outpatient therapy, home health, hospice, SNF, surgery, anesthesia, hospital costs, etc. But we're all going to bundle payments. And this, again, is just sort of another slide we've used in the past about the importance of strategies and the competencies. And again, it falls back to dyad leadership and including the physicians. I think you're sort of getting where we're going to. Align hospitals and providers across the care continuum. Integrated information systems. We're very close. We start Monday with our doctor's offices. So starting Monday for the first time, all of our doctors will be able to see everything on a patient throughout the system. So they come in Dr. Smith's office, and then he refers to a specialist. When he gets there, they can pull it up and see exactly what was done 30 minutes earlier in the live system. First time we ever had that at Wellmont. And that'll be in the hospital system March 31st. So in March, it'll be total open communication throughout. And some issues today that we deal with is, like Mountain States and Wellmont, we have feeder hospitals, we call them, that are just locally based facilities that feed everything to our tertiary care centers. And for us, it's Bristol and Houston Valley. Is that, it's not uncommon in the past to come into a Lonesome Pine, a Mountain View, or Hawkins County, have a CT scan, MRI, be put in the ambulance or flown to Houston Valley or Bristol. As soon as they get there, what do? CT scan or MRI. 2 reasons. First of all, it's not in the system. Second of all, we don't have to test results. So now in the EPIC system, we know right away the results will be there before the patient gets there. So we know right away in EPIC the results of our efficiency are going to improve tremendously because of the EPIC system. And this is where we're going to again, aligning hospitals and physicians. We've been down here. We've tried to pacify the doctors for a long time now. We all realize we need the doctors and they need us. So for the first time, we're moving, up to the upper right corner when you do your quadrants. Everybody wants to be in the upper right corner, right? Everybody wants to be in the lower left corner. So you can see that we've really stepped up the process out of need because of healthcare reform. Also because, again, the decline in reimbursements is huge for us. I mean, at Wellmont, we know we're not going to get probably another 16, 18 million next year from Medicare that we got this year. You take 16, 18 million out of a system up to what size it is, you don't replace it. So a lot of this is being forced to survive, and which is also not bad. Using evidence-based practices for quality improvement. Again, we're moving everything up to the right side with more aggressive strategies. I'm going to breeze through a little bit of this. I know we're getting close to time. Difficult to make predictions, especially about the future. Yogi Berra. Can probably be more applicable to healthcare. Everybody agree? Literally, we've had meetings today in the last 3 months, and we go in tomorrow, and something's totally changed from what we talked about yesterday. And I'm sitting there thinking I'm getting too old for this business. But it's good. It's a fun time to be in a business. Actually, the last 90 days, and I swore when I got out a few years ago I'd never go back to a healthcare system situation. I've probably had the best 90 days of my whole career, the last 90 days. It's been the most enjoyable process because I really feel like we're making a change for the benefit of the patients for the first time in my career. I feel like the patients are getting the focus, not the bottom line. One can't run a hospital without doctors, one can't run a hospital without them. Can't tell you who said that. Anonymous CEO. True statement. All right, I want to breeze through this. We still okay time-wise? Our post-acute initiative, we went to the market. I'll give you a quick overview. I'm going to go through some of these slides. And Colin was part of this process. I guess maybe after you left we started. But we went out and we figured out we're sending our patients to like 65 different SNFs or nursing homes. And we realized, we've got to do a better job of knowing where they are, what's happening to them, what's the quality, what's the readmission rates, what's the bounce back rates, etc. So we actually went through a process and we interviewed and had 40 of them do surveys. And we actually got 24 complete surveys back. Out of those 24, this is over 18 months. We went through the 24, we had individual meetings, we chose 8 to do alignment agreements with, and we're actually starting January 1st. Formal agreements, you'll see as I go through the slides. But again, all this is being done because we're trying to prevent readmission rates and raise the quality because it's financially driven. But again, at the end of the day, who's going to benefit? The patients are benefiting tremendously during this process. Who would have said 5 years ago, a cardiologist will come to the nursing home? Nobody. No cardiologist would go into a nursing home 5 years ago. Wouldn't happen. Had no reason to. So we've gone through, why are we doing it? Obviously, we're trying to optimize patient outcomes and reduce care costs. This probably should be number 1, not number 3. Reduce inpatient length of stay. We're trying to raise the acuity level in the nursing home setting. And to do that, what do we have to do to help? Do you need more wound care education? Do you need more CHF education? Do you need more pharmacy education? We're willing to put resources into your nursing home for you to take sicker patients quicker. Why? Because it costs us $7,500 a day. It costs you about $200 a day? $400 a day. So we've got a financial reason to get them out. Also, if that's where they really can be and can be taken care of, that's the most appropriate setting. Where should they be? The most appropriate setting. Right now, we have a large percentage of patients every day that are not in the appropriate settings. So if we're at 40% and we can raise that to 60%, again, the patient benefits if we've got another 20% in the most appropriate care setting.
But did you ask what it costs?
Yeah.
Oh, yeah, about $200.
About $200.
Cost the hospital to do it.
Right. Yeah. Mitigate readmissions we've talked about. Pre-position providers take episodic risk. That's coming through ACO market in the bundle payments. So we've got 8 we're working with now. We may only have 2 of those 8 that qualify for at-risk contracts. So we'll go back to them and say, we think we can take your quality measures in to this at-risk contract. Will you join us in this at-risk contract? So that's eventually where we're going to go with this. And we're talking about must coordinate care beyond the hospital. For the first time, we talk about care beyond the hospital. We never talked about that in the past. We only cared about what happened inside our walls. Now we worry about what happens outside our walls more. Here's what we found out. About 20% on average of Medicare patients go to home health, SNF, inpatient rehab, or some kind of LTAC setting. At Wellmont, we only send 13%. So if I'm a SNF, an LTAC, or home health, LTAC, when I see that, what am I thinking? There's more business for me. For some reason, Wellmont's not getting the other 7%, which is a large number, into some kind of post-acute setting. We're going to help get that percentage up. Here's what we looked at. Last year, we sent $79 million out to the post-acute world in the Tri-Cities market. So and you can see SNF, $34 million we sent out in business to the SNF setting. Here's the reason economically. SNF setting, 7.3 length of stay for our patients going to SNF. The geometric length of stay for Medicare is 5 days. We're 2.3 days over. That equated in us losing $3.2 million last year by keeping people 2 days extra that should have been in a SNF setting. So now we're drilling down on each case, finding out why they're staying beyond 5 days and trying to resolve that problem. Again, the need for the relationships with the SNF. Alignment, we're actually doing an official agreement at this time with these facilities. It's not financially driven at this time, but it does have teeth in the agreement. It's got a scorecard. If they don't meet the scorecard on a regular basis, we'll pull them off the alignment agreement, and you'll see the benefits to the facility here in a minute. Patients still have the ultimate choice. Medicare says patients choose where they go, but we're going to try to influence that through education. Patient choice, highlighted. Health system brand alignment. We think the Wellmont name in our market has value. So as a nursing home, you can say, hey, I'm an aligned partner with the Wellmont Health System. We think that brings value to them. Obviously, you're going to get referrals. So if you're one of the 8 partners up front, we're trying to direct all the business to one of those 8, you're getting referrals. We will change referral patterns. Part of that being the fact that we're changing referral patterns is somebody could come back to us eventually and file suit against us saying, you closed my business down because you changed my referral pattern. Well, we've got data that's about this thick that we did over 18 months that shows why you weren't selected. And we got a facility that had a 100% readmission rate on knee replacement surgery patients. Guess what? We don't see knee replacement surgery patients at that facility anymore. So those are things we found out through the process. Ability to take higher acuity patients safely. What do we need to do to help that process? We're willing to put resources into play to help that process. Closer relationship and positioning for future partnership opportunities. That's the risk sharing or episodic payments coming about. We did referral patterns. We looked at we had a post-acute summit. We did a survey. We also did a survey of our case managers. So we got an opinion of our case managers. One thing we did during this process is we didn't share any facility's information with another facility. We've got it together, but when we meet one-on-one, and we only share with them the outcome. We don't share with their competitors. Why? If you bring them together, what do you lose? You lose the focus of what needs to be done in their facility. So in Facility A, they may need help on wound care, so let's work on wound care. Facility B may have a very good wound care program. They need help on CHF, so let's work on CHF. So we're keeping the autonomy of looking at each facility independently. Right now, we've had initial steps. We're doing regular meetings, and agreement execution is actually in the legal department right now for signatures for drafting. So we're pretty close to signing the agreements with the 8 facilities. Contents include an initial set of priorities, statement of commitment. It's not a joint venture financially, but it does have teeth with it, and it'll void if the outlined set of expectations and core performance measures are not met. And you'll see the scorecard here in a minute. Survey results. Colin, no surprise?
Actually, I was the one that filled out that survey before I left.
Okay, so you saw the survey.
Yeah.
So this is okay to share. This is the number of referrals we sent. So we sent twice as many referrals to NHC Bristol. Do we have an incentive to work with them? Yeah, absolutely. Do they have an incentive to work with us as much? We hope.
Well, I mean,
you know.
Can't speak for them,
right.
but yeah.
Yeah. You want to keep those 350 referrals?
Yeah.
Yeah, absolutely. Anyway, so we'll see how we broke it out. And then we did 54 case managers, and we talked about responsiveness to patient referrals, requests for sufficient information, readiness to receive patients, and responsiveness to follow up. One thing we realized is that we're standardizing the list of information initially goes out now. So we got a list of like nine pieces of information that we send out electronically now instead of maybe sending 3 and then getting requests for additional replacement. We're now sending out a standardized list of information to those 8 facilities. And then we went through the responses with each of the facilities independently and met with them. We also asked, what can Wellmont do better to the nursing homes? They said better documentation and patient information. And we have changed that. We got a standardized approach now. More clinical education and hospital support. One thing we're doing on the hospitals program, and I'm going to get to right quickly, is we will have a hospitalist on call for the post-acute facilities. So when there's a need in the middle of the night for a patient issue, we call a call center. They'll be connected to the hospitalist on call that has information on that patient. So there'll be a discussion with either a nursing staff member or medical director or family member about that patient instead of just putting them in the ambulance and sending them to the ED. Improved education of patients and families. You know, I've heard time and time again that, you know, the doctor in the hospital said my mom was going to NHC and she's going to be 100% better in 8 days and be home doing all of her activities again. That's a false picture. So we've got to do a better job in the hospital setting and saying what are the realistic expectations of your family member by going to the rehab setting. In earlier engagements of patients in the discharge planning process. One thing we'll do in Houston Valley with our new hospitals program in June is we'll put Project Red into play, which is a re-engineered discharge planning process. Physician-led teach-back method. That will address that area right there. So the physicians will be leading the discharge planning on day 1 of the admission, not the last day of the admission. And it's got to be a teach-back method as they do that. This is a survey. So what we're tracking initially are denials. We want to know why any of the 8 facilities denied a case. We're going to be tracking medication errors with intervention. We're going to track unplanned hospital readmissions, patient family satisfaction, referral to admission throughput, and payer acceptance rates. And then eventually we open all this scorecard up as we progress. So that's what we're looking at. Each facility's got to take equal number of unreimbursed days based on their size. So if you've got a 200-bed facility, you may take 150 days a year of unpaid versus somebody's got a 100-bed facility that'll take 75. We may actually compensate those days if they're in the alignment agreement, so to get them out of the hospital setting. Okay, real quickly, the hospitals program we set up October 1, quality driven for the first time, coming out of the production model where everything was about see as many people as you can see to get paid the most each day, which is usually 25 to 30 patients a day in a hospital setting. Don't care how good a physician you are, if you start seeing 25 patients a day in a hospital setting, at some point in time you burn out and you lose good physicians. Our model we set up is based on 12 to 14 patients a day. We see them twice a day. Once a billable charge, once a non-billable charge. Our physicians come in at 7, we're finished by 2:30 or 3. They leave. Next group of doctors come on at 4 o'clock, stay till midnight, take care of the admissions, the heavy traffic in the ED. They're done at midnight. Third set of doctors come in at midnight, handle the nighttime staffing. They leave at 8. 8-hour shifts around the clock for doctors, no burnout, 12 to 14 patients a day. In the month of October, very first month we set up, I had no complaint on a brand new practice in a large tertiary care level 1 trauma center, thanks to the physicians that joined us. When I went back to a good friend of mine, I said, this is what I'm doing at Wellmont. I need you to come join me. He's a physician that's worked with me a lot in the past. He said, that sounds really good, but there's no way you can do what you're saying you're doing at Wellmont. And I said, we've got the full support of the Wellmont system. John, we're doing this. I need you to come join us. And he did. And he told me that last Wednesday we met with the doctors in a lunch meeting. And the doctors were talking about, I can't wait to come to work in the morning. I get to spend time with my family in the afternoon. I'm providing patient care. I'm spending 20, 30 minutes a day with my patients. Month of October, we cut the length of stay from 4.7 to 3.4 days at Huston Valley. 1.3 day correlates to, it's $300,000 per tenth of a day per year. So figure that out. It's a little bit over $3 million that we just saved in October in our hospital's practice, being integrated. Patient satisfaction. We look at a chart every day. It's red light, yellow light, green light. First time in the month of October, all 14 lights were green for inpatient satisfaction at Huston Valley. What do? We took a production-driven model that has survived traditionally through healthcare reform, made it quality-driven. And what do we do in the first month? We saved probably $4 million. Who benefited? I know we did, but who benefited? Patients. Why? Length of stay is a day less. They probably had less consults because the hospitals had time to drive the case. We talk about driving the case. You don't drive it through consults. You drive the case. They get to spend time with their patients. So the quality-driven model works, and when it's working at a high level, it takes care of the financial bottom line for the healthcare system. I'm finished. I could spend all day on the hospitals program. It was a large process, but anyway, we're off to a good start. Questions?
I've got it. You're the second Wellmont executive I've heard talk about 2 systems likely not being able to survive in one area. What's behind that? We know that the new Mountain States CEO that's coming, not really any experience in this other than, I think, integrating past systems, I think. What's that going to mean for the area? What will that mean for administrative jobs in the area? What do you think? You're the second one I've heard say that.
Yeah, I think at some point in time you at least got to see the systems work together. I mean, and I think the same way with physician-hospital relationships, what's happened in the past is the past. And if you want to move forward, the systems have to work together in some form or fashion. Whether you fully integrate them or not, I don't know, because you've got debt to deal with and all kinds of issues. But what's going to create for the people coming into the healthcare market is somebody that's coming in that is going to have the initiative to take charge of a certain area, because one thing we are doing in the healthcare system is it's become a very leanly managed system. So when you bring people in, you have opportunities to take on additional initiatives, different roles, different projects. You get an opportunity to prove yourself now in the healthcare system. I think in the past, once you came into a role, whatever role it was, whatever department, you sort of got stuck in that area. Well, now there's so many opportunities that you can see to take charge, and we're encouraging that entrepreneurial spirit in every position. So I think when you say that is, I'm not sure where you enter the marketplace, but it's not capped anymore. And I think the combination of working together is going to create even more of those relationships. I think the more you work together, the more dyad relationships you need to create too. And right now there's 1,700 physicians in the area, probably how many managers, not 1,700. So a lot of opportunity in the healthcare field. you really can because when you get in somewhere, you'll see it, you can improve the process. And if you're willing to do that, you'll benefit from it. So I think the healthcare reform is going to continue to create people that have that kind of spirit.
Are you transitioning from an existing EMR system to Epic, or are you going from, I would think, paper to Epic?
A little bit of both.
Okay.
We're on McKesson's system now, which is physician order entry, still paper charts or progress notes. We are going from combination of electronic health record and paper charts into Epic. Epic's been a 2-year process, and I think last I saw last week, we had something like, I forget, maybe 800,000 man hours invested in Epic training. So it's been a huge undertaking for us. Matter of fact, starting Monday, I would think you'll see a lot of things stand still at Wellmont as far as what we're working on to get us through the first week or two of the transition.
Yeah, I've been through an Epic transition myself, and the first week is...
Yeah. I've used the Epic system in the past when I was doing some work in Texas, and it's a pretty good system. And it's the dominant system. My understanding VA is going to Epic system, which VA had a good system. But I understand they're even moving to Epic maybe in 2018 or something like that.
I think it's like 40% of the market.
It is. It's projected to be maybe 60% of the marketplace. Yeah, very good system.
I don't mean to dominate. I'm actually a little confused on why 24 out of 40 subacutes responded to that survey. Do you know why that is?
Yeah. What were you thinking?
What were you thinking?
Yeah, I think combination of things. I think first of all they didn't think we'd follow through on the alignment process because most of those 16 didn't respond, have come back and won't know if they can still respond later. I think part of that too is there's transition administration in nursing homes.
Yeah.
So it's not uncommon to have 2 or 3 administrators in the same year, so it got caught in transition. But now 2 or 3 of the key ones that didn't all of a sudden have come back in later and say, is it too late for us to get in the game? And it is a little bit too late. We're going to get to level 2 agreements with them. So, but yeah, you're right. Why would you not put out the survey?
Other questions, comments? Well, good luck. I mean, this is very exciting. Certainly in a time of change and uncertainty, it's wonderful to hear that you are putting those processes in place that will, ensure the best possible care for the patients while, maintaining, I guess, physician motivation, which is perhaps at an all-time low across the country, and obviously, the financial viability, of the health systems. It's a lot of competing, demands, but it seems that you're on the right track. So thank you today for sharing with us, what you're doing. I'm sure it was very, helpful for all of you. Thank you very much to Mr. Chesley, for inviting our expert this morning.